evening. Welcome to the POSI Assami webinar on the congenital pseudoarthrosis of the tibia. We are really fortunate that we have an expert on the subject, Dr. Dror Paley from USA with us. He is probably having the largest personal series on this topic. This is really a challenging topic and we are really keen to listen to his suggestions how to deal with it, this difficult subject. Now I request President of Assami India to introduce Dr. Dror and the panelists. Over to you, Manish.
Thank you, Dr. Dhiren. And this is our third webinar with Professor Dror Paley. He's very popular in India. I think most of the webinars, I think the maximum audience is with Professor Dror Paley. I've checked it. So, and Dr. Dror Paley does not need any introduction in India. And but to people who have attending this webinar for the first time, he is from US and he has an Orthopaedic and Spine Institute in West Palm Beach, Florida. And he's author of the book Principles of Deformity Correction, which almost all our orthopedic surgeons have it. It's a kind of a Bible for deformity correction. And Professor Paley had his initial medical education in Canada and he did his fellowship with Professor Elizaro. And he was his first student from America. And also he did his fellowship from Lico, Italy. He's a true friend of India. Welcome to Professor Dror Paley. Welcome. I also would like to, introduce Dr. Hitesh Shah. He is Professor of Orthopaedics and Head of Pediatric Orthopedic Units at Kasturba Medical College, Manipal. This actually is the same institute I also did my MBBS. So he belongs to my institute. And he has published an article in Journal of Pediatric Orthopedics, What Factors Influence Union and Refracture of Congenital Pseudoarthrosis of the Tibia. And it was a multi-center study. Now let us see with Professor Paley's, experience and Dr. Hitesh Shah article, what best we could get. Dr. Ruta Kulkarni is Associate Professor of PGIO of Swasti Rog Pratishthan, Miraj, Maharashtra. And she's Vice President of Assami India, and she's a limb reconstruction and pediatric orthopedic surgeon. Fortunately, I also did a fellowship in the same institute long time back, 15 years back. So I welcome you all. Over to Dr. Dhiren Ganjawala to start the question.
Yes, Dr. Dror, now you can share your screen and start the lecture. Thank you.
Okay, thank you. All right, very good. Well, it's nice to be back again, and I hope everyone is staying safe. So we're going to talk about congenital pseudoarthrosis of the tibia, and I like to throw up this provocative title, 100% union with no refractures. So that is what we aspire to. We aspire to achieve union in all cases, and to only have to do the treatment of the pseudoarthrosis once so that we won't have any future refractures. As we'll discuss, that is not the typical outcome for most patients. And we're going to talk about what's called the cross-union protocol. So let's talk a little bit about pathoanatomy. So the CPT pathology, we know that there's a fibrous hamartoma surrounding the bone. And this fibrous hamartoma, hamartoma just refers to basically normal fibrous tissue. But when it's been studied, people have found that there are more osteoclasts and a higher osteoclastic activity in this tissue. Furthermore, there's a synergistic response of the bone from biphosphonates and bone morphogenic protein. One of the reasons for that is that the bone we know this for neurofibromatosis CPT, the bone in NF, for example, NF CPT, specifically, produces less bone morphogenic protein than a similar amount of bone from non-NF. And that combined, that less response to osteogenesis, therefore, with a greater osteoclasis, you've got two really bad defects. You've got a defect in anabolic and catabolic metabolism of the bone. Now, let's leave the pathoanatomy. I think it's important to understand it because it'll be part of our treatment. And let's discuss what is a successful treatment. And there could be many definitions of this, but probably the most basic is that there needs to be union and there needs to be no refracture. And in the past, every paper that's published talks about the union rate and talks about the refracture rate. But no paper has ever combined the two probabilities together. And therefore, it's actually misleading because we're not aiming for union alone. We're aiming for union without refracture. And union alone is not worthwhile if 3, 6, 9, 12 months later, you have a new fracture. So we know that when you multiply two fractions together, you get a smaller fraction. And so the success rate is really the union rate, which is a number less than 1, times 1 minus the refracture rate, which is therefore a number less than 1. And so that the product of those two is going to be a lower rate unless union and refracture, union 100%, refracture 0. It's the only situation where you could get success rate being 100%. So when we look at this and apply this to the literature, publications in the literature, and we can look, I did my own meta-analysis. These are a bunch, and these are mostly papers since 1990. Most of them really from 2000 on. But you can see here for IM rotting, there's a whole bunch of papers, and the success probability, you can see listed down here. Refracture rate's here, union rate is here. Ilizarov method, Ilizarov plus rotting, free vascularized fibula. These are the most popular techniques. And what you see is that at the bottom, the average success probability is only 50%. That's really disappointing. I mean, you've got some studies. Let's see, here's a really good one. Look at Barzunov et al. 2015. They had 28 patients, 100% union rate, 61% refracture rate. So their success rate is 49%. That's the message. So even though you've got 100% union rate, you have such a big attrition due to refracture that your success rate is just under 50%, and so on. Now, there were two recent studies, both from 2018. One was Cancellous et al. In JPO 2018. They did a meta-analysis of 401 cases, of which 300 united, 75%. They had a refracture rate of 35%. So 75, that should say 75%, times 1 minus the refracture rate is 49%. So they ended up with a 49% success rate. Another study in the same year, 2018, multi-center study, 109 cases, 102 of them united. So it's 86% union. Refracture 42.5%. So 86 times 1 minus 42.5 is 49.5%. So their success rate is only 49.5%. You notice that the probability of union with no refracture in the literature, that's 3 separate meta-analyses, 50%. It's about 50%. So and you can go back actually a long time ago too, we have not passed that number. I look at my own study. I've published 7 papers now. I have 7 publications on CPT. My first one was 1992. And when I look at my first study, I think I had 92% union rate, but initially I reported a 25% refracture rate, which then became 73% refracture rate. So when you multiply 90%, 73%, you know, you're dropping way down to about, you know, 60%. No, I'm sorry, well below 50% success rate. So this is really important and really significant. Why can't we seem to break this barrier of 50%? And this is for all published techniques: vascularized fibula, rodding, fixators, fixator with rodding, bone graft, BMP, all of the above, about 50%. So I published a paper, and it's the 3rd paper on this subject. I've published 3 papers about the cross-union technique. The first 2 are written as book chapters, and the most recent is in Journal of Children's Orthopaedics, 2019. And it's a worthwhile read, I think, so you should pull that article. And don't just get that article, but you'll see on the back page, it says supplemental material is available for this paper at this online location. And so you can download the online location to this link, and that'll give you the supplement. And they wouldn't let me publish all of the illustrations, but they would online. So in the print, there's only the article, and in the online version, there's the supplement, which has all these beautiful illustrations that you're going to see today. Okay, so let me take you through this technique that we now use, and then you'll see what the results of that technique are. So it's called the cross-union protocol. The first step is to give zoledronic acid. So we discussed that these patients have a increased osteoclasis. So we want to stop that osteoclasis. And in fact, anybody who's treated this condition has seen it. In fact, you even take a bone graft, and the bone graft gets resorbed so quickly. So we want to stop that resorption. How do we stop it? We give some type of biphosphonate, which you know then makes it impossible to resorb bone for a period of time. Zoledronic acid is a 3rd generation biphosphonate, so it prevents resorption for longer, usually at least 3 months. Now, why do we give it preoperatively? And this is the key. And in fact, I do need to give credit to David Little, who is the first one to kind of recommend the use of a biphosphonate, and specifically zoledronic acid, for CPT. But he was giving it after surgery. So it makes more sense to give it before surgery. Why? Because in addition to getting into the CPT bone, it also then will get into the iliac crest. And when we harvest the bone graft, it'll make the bone graft non-resorbable. Now, why 2 weeks before? So there is some in vitro evidence that zoledronic acid inhibits bone formation. And so if you give it 2 weeks before, that whole inhibition of bone formation is gone. And all you have is the inhibition of bone resorption. So after we do that, 2 weeks later, we follow through with the surgery, which I'm going to go through in detail. It's a multi-step surgery. And then 3 months later, we give another dose of zoledronic acid. Why do we give a second dose? At this point, the bone is already healed, but you have a lot of new bone. and that new bone does not have zoledronic acid in it. So we want to make the new bone non-resorbable in case there is any recurrence of the hamartoma tissue, the periosteal type tissue that resorbs the bone. So we're making sure that the bone graft has it, the CPT bone has it, and then later the newly formed bone has all of the biphosphonate in it. So none of the bone is resorbable. This buys you at least 6 months, where nothing in the tibia is resorbable. And at that point, the zoledronic acid, effect wears off. It probably lasts more than 3 months, but the full effect is for 3 months after an infusion. The other thing I want to introduce is a new classification. Why am I introducing a new classification? Because I honestly don't feel that any of the classifications that are out there are particularly useful. Now, when I say they're not useful, what does that mean? Well, they're not useful. I mean, what's the purpose of a classification? The purpose of classification is two main things. It is to stratify the disease, CPT, into different groups, so for comparison. So whatever a type 1 is, if someone else publishes the results of type 1, we can compare my type 1s with someone else's type 1s, my type 4As with someone else's type 4A, and so on. The second thing is it needs to relate to the surgical technique. So it has to guide treatment. So the treatment for type 1 would follow a certain algorithm. The treatment for type 2 would follow another algorithm. Type 2B, another algorithm. So each type has its own algorithm for treatment. So it guides that. And lastly, ideally, a classification hopefully will also predict prognosis. And I like to, classifications are organized one of two ways. They are organized from the best to the worst or the worst to the best. I personally like from the best to the worst. So the least involved case is type 1. What is type 1? It's an anterolateral bow with no break of the tibia or fibula. Type 2 is, so it's in Crawford's classification, the pre-pseudoarthrosis. So this is the what he calls tibial dysplasia or pre-pseudoarthrosis. In type 2, we have a break in the fibula only. So the tibia is intact. All of the A's mean the fibula is at station. That means the fibula is where it belongs, which is the distal physis of the fibula at the level of the mortise. Type B means the fibula has migrated up so that the physis of the fibula is above the level of the mortise. So 2A and 2B both have only a fibular fracture, but they have station or above station for the level of the fibula. Type 3 is when you have a fracture in the tibia, but the fibula is intact. Obviously, if the fibula is intact, there's no A and B because the fibula is always at station. That's why also type 1, which has an intact fibula, it's at station. It's only when the fibula breaks that it can move away from station. And then type 4 is a fracture of both bones, tibia and fibula, and the fibula is at station for 4A, migrated up from station at 4B. And then I added one more group, and this is 4C, and this is really where you have a bone defect. So it's not just atrophic bone ends, but a bone defect present. 4C is typically seen after a patient's had treatment or if the CPT has been neglected for a very long time. Okay, so, okay. And we're going to talk about that the treatment from type 1 all the way to type 4B is one version or another of the cross union. The only one that has a different treatment would be 4C, and that's where 4C is where you get into bone transport versus acute shortening. Okay, so let's take a model of a type 4A. So fibula at station, both bones broken. So we make an anterior incision along the crest of the tibia. This incision should be from the level you want to achieve a cross union to the other level you want to achieve a cross union. Distally, you are limited because you can't go past the growth plate. Okay, so the incision is anterior here. This pink color is the hamartoma. You can see at this level, the cross section, there's two parts of the tibia overlapping. That's why you see two bones here, and that's the fibula. The fibula pseudoarthrosis is at a lower level, so at the cross section, you only see one. This shows you the major vessels, and this is the interosseous membrane. So the very first step is you elevate the anterior compartment. So you do a complete fasciotomy up and down, and then you lift the entire anterior compartment, including its neurovascular bundle, off of the interosseous membrane and off of the fibula and tibia. You then go to the medial side and you open up the deep fascia of the deep posterior compartment. Now I'm going to digress one thing, and it's not well illustrated, but when you make this incision, one little trick that's important, there is a thin fascial layer here, superficial fascia, and it's stuck to the hamartoma. You should separate it because you should leave a thin fascial layer with the skin. If you don't do that, you can get necrosis. So when you lift this off of here, you can see you're lifting this off. There is this thin fascial layer. This is not obvious in the distal incision. It's more obvious up here. So a lot of times I'll start up at the top, find that layer, and then as you go down, the inflammatory process of the hamartoma just fuses to this thin fascial layer. It's very hard to separate them. Keep them together because the plexus of blood vessels for the fat and skin runs in that fascia. So you get much less risk of any incisional problems. And we had a couple in the beginning until we understood that. So now you do a longitudinal fasciotomy of the deep posterior compartment. And then you go along the back of the hamartoma till the interosseous membrane. And depending what level, you'll see also the perineal vessels, perineal artery and vein. Sometimes they're covered by a little muscle. Once you've done that, you then resect the interosseous membrane. Where do you start? You start at the level that you're going to do the cross union. So from one end to the other, you have to determine that in advance. You then incise the hamartoma of the tibia, and you open it in the front, and you go circumferentially around the bone. Now remember, you've already peeled back the muscles in the back, so it's actually quite easy to cut around the back. The only danger area is distally because of the perineal vessels. I try and preserve them, but there's no great, problem if you lose those vessels. So you do this on the tibia, and then you do the exact same thing on the fibula. Even if the fibula periosteum seems normal, you need to take it down. And the reason is because if you don't do that, you won't have anything to unite to. So the tibia and the fibula have to be bare of any surrounding periosteum or hamartoma for the entire same length, even if they're pseudoarthroses that are at different levels. Now, once you've done that, the bowing of the tibia will straighten out automatically. Now, when you straighten it out, you are going to end up with overlap of the bone ends because of tightness of the tissues in the back of the calf. Now, when you look at the bone overlap like this, you're going to then square off each end. So you put a little traction on the leg and you square off the ends. So that way you're going to put these two ends together like that. Only do the tibia. This is done with the saw. Only do the tibia. Next thing is you insert a wire up the tibia in a retrograde fashion, coming out through the epiphysis in front of the patella. You follow that with a cannulated drill. Distally, you do the same thing, cannulated drill. Now, you measure the length of this canal plus the length of that canal, and that will help determine what length of male and female telescopic rods. Now, we use the Fassier-Duval nail, and I know there are many different types on the market. So the advantage of this, it screws into the epiphysis. At the distal end, there's two different ends. The one made for osteogenesis imperfecta has a corkscrew. This one here has a locking hole. And you should use this type and not the corkscrew. So you are going to bury this and lock it, and this screws into the epiphysis. Okay. Anyway, this is picture with the male introducer, putting the male end into the epiphysis. So you've reamed already down to the epiphysis, and then it's a small hole. We put in a 1.5 millimeter wire. We use an Elizarov type wire. We go through. It's not that hard. You magnify this on the image intensifier and you can get in. So you go across and then you come out the skin on the other side. You curl the end, make a little incision, pull it back, and then you curl the end here as well. So you should have nothing protruding. You then put the female end inside. So you screw the female end into the epiphysis. And now we're ready to put on the plate. So now we take, we use, there's many, it's a very thin, small locking plate. Synthes makes one, I've used that. Smith & Nephew makes the one that we use most of the time. So these are like mini plates, but they're long and narrow. And so this plate, very low profile, we slide it subcutaneous, but extra periosteal up here. And then of course it's sitting on the bone in the rest of the way. You can mold it a little bit, but it's okay for the plate to be a little bit off the bone. The reason is because when you bring it down with the screws, it'll actually compress the bone because it deforms the plate, which pulls the bones together. So you then put in one screw at the end, another screw at the end, and then the rest of the screws. Usually 3 screws at each end. Once you've finished with that, you then now go to the fibula. You overlap the fibula, but before that, you pre-drill it with a wire. Now, it could be a 1 millimeter wire, a 1.5, a 1.8, whatever fits that caliber of the fibula. And then you have your fibular wire in up to here. You then cut one end of the fibula, overlap with the other end, and you bring them together and advance your wire up the fibula. You cut it at the end and curve it and bury that wire. The last step is to burr the opposing surfaces of the bone. So you now roughen up the lateral surface of the tibia, the medial surface of the fibula, okay? And then when you're done all that, you then go to get your bone graft. So you're done with the leg. All of this is done under tourniquet. So we do use a tourniquet for this operation. I can tell you that all of this that we've done so far is about an hour and a half to 2 hours. Okay. So the fastest I think I've ever done it is an hour and a half. And all of them I do in under 2 hours. Probably you're going to take longer, you know, your first time. So now you go to the apophysis and you make an incision. This is not a typical bone graft incision. We're going to harvest all of the cancellous bone from inside the ilium bone. So everything down to the acetabulum, SI joint, sciatic notch, and so on. So in order to do that, we have to split the ilium. Now, how do we do that? We cut the apophysis from the inferior spine to the superior spine. I decompress the lateral femorocutaneous nerve to protect it, and then split the rest of the apophysis. I then cut a window of periosteum from the undersurface of the iliacus muscle. Iliacus, even into adulthood, has a thick layer of periosteum. So we take that periosteum and we mesh it. And you can either apply it right away or come back later and apply it, but keep it moist. We then take our osteotomes. Now these osteotomes, most of your hospitals don't even have one of these osteotomes. Can you mute yourself? If somebody's speaking, just mute yourself.
Please mute yourself, please, everyone. Sir, continue.
So we then use these very thin, sharp osteotomes. Now, what do I mean by thin? I mean, these are thin enough they cut like a knife. That's how thin. Now, no manufacturer makes these. So you take your osteotomes and you go to that guy on the street, I've seen them in India, who sits there with the wheel and sharpens everything. And you get these sharpened. I have my osteotomes sharpened by a guy who comes in every week. Every week he's sharpening osteotome. You know, eventually the osteotome is losing metal and you have to get a new one, but we sharpen it. These are so sharp and so thin. So you need a thin, sharp, narrow osteotome. And then you start at the inferior spine, going all the way back. You have to split until the posterior spine. Okay? Once you've split all the way, you go down centimeter at a time. So you go 1 centimeter deep, then 2 centimeters deep, then 3 centimeters deep. So you keep going deeper and deeper until you get to the acetabulum, triradiate cartilage, SI notch, SI joint. Only when you've split it enough do you then lever medially, never laterally, lever medially to open the ilium. And it opens like a book, like a clamshell, really like a clamshell. And you start scooping out the cancellous bone all the way down to the triradiate cartilage and to the acetabulum. You take a lot of bone. Now, most people, this is the hardest step for them. First of all, they don't have the sharp osteotomes. Second of all, they keep coming out. They go in and they go out. So they just make a mess of the ilium. This is something you have to learn. This is where you're going to fail. If you don't get enough bone graft, you're going to fail. Okay? So very simple. Not enough volume, you fail. So watch this. I mean, you see the osteotome going in. That's how deep it's going. You can see it going to the SI joint in the back. And then you have the curettes going in and scooping out everything. And you can see that the bone on the supraacetabular region, and now all the way to the triradiate cartilage, to the dome of the acetabulum, to the sciatic notch, to the SI joint. You can see we've hollowed out the whole thing. And all you're left with is cortical bone. I'm not interested in cortical bone. Cancellous bone produces 10 times the amount of new bone than cortical does. Now, you can read many authors, including Benjamin Joseph, who've written that cortical bone is it's the holy grail. It's what you need. So I respectfully disagree. The rationale behind the use of cortical bone is only two things. And one was it's a little more resistant to resorption. And the second is that if you get union at one end and get union at the other end, it acts as like a biologic plate. So I don't need resistance to resorption because I gave the zoledronic acid. So we gave zoledronic acid, it stops resorption. And we gave it before surgery, so it's inside this bone graft. Secondly, I don't need a cortical bone plate. Why? I have a metal rod in the tibia, a metal rod in the fibula, and I have a metal plate on the tibia. I don't need more fixation. Got plenty, and I'm never taking that rod out. I'm going to change it, but I'm not taking it out. So, but what do I want? I want to heal quickly. How do you heal quickly? Cancellous bone. You need cells. I want osteogenesis. How do you get a lot of bone? Cancellous bone. Okay, not allograft, not the mother's leg. I know a lot of people are doing that. No, patients own autogenous cancellous bone. Nothing is better. Cancellous, not cortical. You want to get at least 20 cc's of bone in most cases. The bigger the child, the more. But I do 12-month-olds. So I start this procedure at 12 months and I don't get less than 15 cc's. And as they get older, by 2 years, I'm getting 30 cc's, 40 cc's. You know, by 5 years, I mean, I got more bone than I could ever use in a 5-year-old. We like, in my first 15 or so, I did not backfill. I did not put anything in here, but now we have this available. It's kind of a calcium phosphate, calcium sulfate mixture, and it hardens into a cement. So it keeps the space here. Calcium sulfate resorbs very quickly. Calcium phosphate resorbs very slowly. So I use a mixture of the two and fill this up, and then close the apophysis, close the external obliques to avoid a ventral hernia. Now, these are the 3 ingredients I use for my cross union. This one I know you can't get in a lot of countries. So bone morphogenic protein. I've done this, like we go on mission trips to Haiti, Nicaragua. I've operated overseas there and in other countries, and I've gotten the same results without BMP. I'd say if somebody says, so why do you need to spend $5,000 more with the BMP? Why do you need it? Plus maybe a theoretical risk of tumorogenesis. The BMP speeds it up and amplifies everything. You get a ton of bone, and all of my cases now are united by 6 weeks time. 6 weeks. Can you imagine? Even the worst CPT, the worst one, has a cross union by 6 weeks and has the CPT united by about 12 weeks. Okay, this is my periosteum, my cancellous bone, my BMP. I start by wrapping my periosteum. I put it under the plate, and wrap it around the bone. Lately, I've been leaving it open on the lateral side, but putting it more on the medial, anterior, and posterior side. It is, remember, it's cambium layer down. It is already meshed with the skin graft mesher that expands it because it contracts on its own. I then put in the BMP in the back. So if you have it, you layer it on the muscle. BMP should always be in contact with muscle. It recruits mesenchymal cells from the muscle and blood vessels, and it recruits them into making bone cells. You then layer the cancellous bone mostly between the tibia and fibula. You can put a little bit anteriorly if you have some left. Not important. Does not have to be on the CPT. You're trying to create a bypass. So it goes between the bones. And then you put a layer of BMP on top of that. And now what you have, lastly, you bring your muscles on top. Remember that fascia from here? I suture that fascia to the muscle, and that keeps it over. So I end up with a sandwich. It is a BMP, cancellous bone BMP sandwich. And it's really a muscle BMP, cancellous bone BMP muscle sandwich. Now, what's the importance of the muscle? Muscle is where your blood vessels are coming from. So that's where your vascularity for this whole bone graft to revascularize very quickly. So you've got a very vascular orthotopic environment. You've got huge amount of stem cells, mesenchymal cells in here in the autogenous bone graft. You've got an inductive factor, the BMP here, that is going to supercharge all of this with growth factors. And you've even got some normal periosteum to help replace the abnormal periosteum that was the hamartoma that you removed. So it's a very physiologic procedure. So don't forget this thing I mentioned, it's not illustrated, suturing that fascia that you preserve to the edge of the muscle, it keeps the bone covered. Okay, when I'm done that, 6 weeks later, it looks like this. It looks already like a bridge. You might not see union yet of the pseudoarthrosis site, but you already have a bypass bridge. So it looks like this. And then as time goes on, you get unimpeded telescopic growth. So you get growth at the proximal, growth at the distal growth plate, and you can see the rod is telescoping. Now, when it telescopes enough, you should replace the rod with the next diameter up and a new rod. Usually, depending what age you start, you have to replace the rod once or twice during childhood. Very important to replace the rod. People who have not done that have had refractures. So the rod is like rebar. It's like having metal in concrete like we do in buildings. So let's take some examples. Here's a kid, 18-month-old with NF. And I've been doing, by the way, so I've been doing this since 2007. And in 2007, I started doing it with an external fixator instead of a plate. All the other steps are like I'm doing now. I used to do not quite as long a bridge, but now I do a longer cross union. But here's the Fassier-Duval, there's the periosteal graft in there, there's BMP, there's cancellous bone. And you can see I'm locked into each each epiphysis. But instead of having the plate, I'm compressing this with an Iluzarov. And you only need 2 wires above, 2 wires below. You don't need much fixation. You don't even need foot fixation. This one did, but you don't need it. And you can see this healed and telescoped a lot. Look how much it telescoped. So it really grew. So that's already, you should be changing the rod. You don't change the fibular wire, but you change the tibia. So here I changed it to the next size Fassier-Duval. And this patient had some valgus, so I put on a hemiepiphysiodesis plate on the medial side. This is not impeded by the rod being present. Now, in 2014, I started using a plate. And here's an example. This is the technique I just showed you with the Smith & Nephew EVOS plate, the Fassier-Duval nail, and a wire in the fibula, cross union. Okay, so this is since this is being done since 2014, and so that's the end of that example. Now, people always say to me, what about really small distal ends? You keep showing us these big distal ends. Can you do that with a plate? So I'm showing you this one on purpose. You see how small the distal end is here. And this is in surgery. This lower end, so that's the growth plate here. The lower end of the tibia, devoid of the hamartoma, is 1 centimeter long. That's it. Here's your cross union. Goes all the way down here. Okay. So, and in fact, it's so short, I needed to put the screws in the epiphysis. So they're not in the metaphysis, they're in the epiphysis. When I do that, then I come back somewhere between 6 to 12 weeks later when I see a bridge on the x-ray, and I take out the screws from the epiphysis and I put some in the metaphysis, but it's already bridged at that point. So I'm now free from the distal growth plate. So it's a very use. So for these, I use a T plate, and the T plates are not as long as the other plates. That's why it doesn't go all the way up. But look at that bridge. 12 weeks later, we have a solid cross union. The CPT itself is already united. Now, very unusual is a proximal CPT. You don't see these a lot. These have been technically harder to get to heal because you have a longer lever arm. You know, in the old days, people would put a rod through the ankle. I saw a recent publication where an Indian surgeon modified my technique and is putting a rod through the tibia. If you're online, stop doing that. Stop going through the ankle. Do not violate the ankle. There's no reason to violate the ankle. You can go through the upper growth plate. Don't violate the ankle. I mean, I don't know where people got this crazy idea that you can just sacrifice the ankle like that. You know, and you know, so many, the Williams rod and the Sheffield, everybody just damages the ankle. That's insane. Don't do that. It's a bad protocol. And everybody would say, well, we don't have such good equipment like you do. Okay, so put a rush rod in from the proximal end, but don't go across the ankle. That's my message to everyone. Don't go across the ankle. And you'll just, if you don't have a telescopic rod, you're just gonna have to change that rod more frequently. That's all. So, I mean, this is a challenge because it's got a varus deformity here, and it's got this, you can, I mean, look on this long x-ray, you see the varus deformity there. So we have to do an osteotomy to get a rod in. And so you can see we did the osteotomy, and anywhere I do an osteotomy, I do a cross union. So I did a cross union at the osteotomy. I did a cross union at the upper end by taking down the perineal nerve, taking down the whole anterior and lateral compartment, preserving the anterior tibial vessels, and then bone grafting around those. Okay, so you have to know your anatomy to do this. And look at the beautiful cross unions we got at 2 levels, which then hypertrophies, and I had a little bit of valgus at the knee, so I added a hemiepiphysiodesis plate. And I mean, look at that, it's gorgeous. And fibulas at station and so on. To show you how difficult some of these get, so we get a lot of failed cases. This patient had 2 previous attempts at surgery and has this recurvatum deformity that you sometimes get in these kids, and also has this persistent pseudoarthrosis, has this middle segment. This was, I think, a fibula from the other side that somebody took and put in here, and that's why it's so thin, so thin. And what you needed to do, so a doctor sent me this x-ray from Italy, and I realized that there's a flexion contracture here. In other words, the only reason the knee comes straight is because you got recurvatum plus a flexion contracture. So I took special x-rays, and where's the special? Oh, it's right here, sorry, on the side. This is a maximum extension x-ray. And you can see the knee doesn't come any more forward than that. It's stuck in flexion and it's subluxed. So this is a tough case. Not only do you have a pseudoarthrosis, you have the recurvatum, you have some lesion here, you have flexion contracture of the knee. Real problem. So I treated it, and this is not 3 years, this is 3-month follow-up, should say 3 months, sorry. It's a recent case. And I could not get the Fassier-Duval in because it's so narrow. So I used, instead, I used what's called a slim rod. Now, here's the step-by-step. So by the way, how do I work this patient up? I wanted to see this patient also stuck in calcaneus, and they're not. You can see the ankle goes into plantar flexion relative to the mortise. Okay, here you see the pseudoarthrosis better. I wanted to see the fibular station. And this is my maximum extension after I did a posterior capsulotomy. So I did a posterior capsulotomy, still can't get the tibia forward. So then I levered it forward to break some of the adhesions. You can see the tibia is finally reduced. So then I took off the hamartoma, went into this fragment, then drilled it, and it was too small for the smallest Fassier-Duval. The smallest Fassier-Duval is 3.2 millimeters. I was only able to get a 2.6 millimeter drill bit in that. So you can see I did an osteotomy right through this terrible bone. I translated it posteriorly and shortened up here, and then drilled across. So now my recurvatum is corrected. You see the slim rod coming down, also made by Pega Medical. So slim rod coming down goes into the tibial epiphysis and holds this together. Then at the distal end, of course, the CPT was rodded with the same rod all the way down to the epiphysis. And then a huge bone graft. And now you have to fill everything. So I had to go from the top here all the way to the bottom. This is about 50 cc's of bone. Now, fortunately, this was a 6-year-old child, so big crest. And look at it healing already, okay? So this is already evidence that it's healing. 3 months later, this is what it looks like. It's completely united. I mean, here's the worst case in the world, and look at it, completely united, plus we corrected the knee flexion contracture. So again, it's about understanding the whole problem, not part of the problem. Okay, so what are the results? We did a retrospective review from February 07 till February 2018. We had 34 patients, 36 limbs, all treated with the cross-union protocol. 18 were treated with the X-Fix method. That was from 07 to 2014. And 18 were treated with the plate method, okay? Notice that the plate group were younger on average. So most of our patients now are between 1 and 3 years of age. That so-called age when they don't do as well. Well, that's nonsense. Age, it does not affect this technique in terms of its success rate. And these are all the various types that we've gone through. Remember, type 1 is an intact tibia. That means we had to break it and it united. Type 2 had only a broken fibula. Type 3 had a broken tibia. Type 4 was both were broken, okay? And then we looked at whether they had NF. 83% of the patients in the plate group and 67% in the X-Fix group had NF. 12% in the X-Fix, 6% of the plate had osteofibrous dysplasia, and the rest we called idiopathic. We had a large percent of failed surgery, about 1/3 of the patients. The Follow-up in the external fixation group was an average of 5 years, ranging from 1 to 12. The X-fix group, the mean follow-up, I'm sorry, the time to removal of the X-fix was 4 months. In the plate, the average follow-up was 2 years, ranged from 1 to 5 years. 4 patients had reached skeletal maturity in the X-fix group. So not everyone has reached skeletal maturity, obviously. We achieved 100% union of the CPT, 36 out of 36. We achieved 100% cross union, 36 out of 36. We had no refractures, okay, with up to 12-year follow-up. It's now already 13 years, I still have no refractures. We had a persistent non-union in 3 of 36 fibulas, 8%. And since then, we learned what we were doing wrong. These were all very low fibulas. And what you really need to do is you got to clean out that hamartoma all the way through the syndesmotic area and then tuck bone graft all the way down there. And since then, we haven't had any fibular pseudoarthrosis. We had very few complications, 1 cellulitis, pin track infection, 1 locking wire at the distal end backed out, had to be repositioned, and incisional skin necrosis in 2. And I explained that to you. I think it's related to that medial flap. Delayed complications, the FD does pull out either proximally or distally. And it happens 17% of the time, and mostly in the X-fix cases. But now I've got a bunch that it's happened in the plate cases. I think that is just circumstantial. It's not actual, only in X-fix. And so getting valgus proximally is not unusual. Why is it happening? It is happening more when you have the pullout, the valgus. And it could be due to what's called stiction friction, which is some tether that the rod is creating. Now, what about the acetabulum when you harvest this much bone? Basically, there was no difference in the acetabular index or C angle between the harvested side and the non-harvest side at 2-year follow-up. We had 4 blood transfusions in this patient group. So what's the origin of the cross-union technique? Well, so credit really probably needs to be attributed to In-Ho Choi, in that they were the first to publish. They published in September 2011, what's called the 4-in-1 osteosynthesis. And I published in 2012, okay? I never saw their paper because mine was in press at the time that the 2011 paper was published. Mine was already in press and written. So we were doing this since 2007. But they deserve credit because they were doing cross-union since 1999. So they were intentionally creating a cross-union. Now, they were doing something else. They were converging the fibula to the tibia. They were bringing them together, side to side. And so they couldn't rod their fibulas. And you can see how the fibula comes in towards the tibia. And that's what they were doing. So you get a much narrower cross union. We weren't doing that. We were doing cross union between the bones. So we have a much wider bridge of bone. Now, they coined this thing called the relative cross-sectional area, which is the area at the cross union on AP and lateral divided by the width of the epiphysis, and in order to standardize it. And what they found was there's RCSA, the relative cross-sectional area, 0.27, while ours with our technique is 0.56, almost twice as big. So we're getting much bigger cross-sectional area. And if you looked at the relative cross-sectional area of they also did a series without the cross-union, and they had a relative cross-sectional area of 0.13. And this may explain why cross unions don't break, while without cross union it does. Because especially in young children, the bone is so narrow that if you have a relative cross-sectional area, even if it unites 0.13, just not strong enough to stay united. Well, obviously, once you hit this threshold of 0.27, they had no fractures. You know, we're twice that and we had no fractures. So refractures. So I think this relative cross-sectional area is really important. So our protocol is different because it spreads it apart. So it's a very different technique, different way of harvesting the bone. They take out an entire cortical window with cancellous bone on the inside and make like a sandwich of that. We don't use cortical bone at all, as you know. They, I don't think, use zoledronic acid. They don't use BMP. But more than one way to skin a cat. So conclusion, we're getting rapid union. It says 3 months, but the truth is the cross union is already healed at 6 weeks. We're getting 100% union of the CPT, 100% union of the tibia to the fibula, and no refractures at an average of 4-year follow-up, but up to 12-year follow-up. And we have 3 persistent non-unions, the distal fibula, but I think we understand now how to solve that by just making sure that you get rid of the hamartoma more distally and clean that area out. So in the end, what I want to kind of emphasize, this is a paradigm shift. Why? Because we went from 50% success rate from the literature, 100 years of literature, 50% success rate. And all of a sudden we jump to double that, to 100% success rate. Now, we're not used to that in orthopedics. We're used to going 50 to 60, 60 to 70, you know, constantly improving. Nothing's 100%. Look, I can only, in my hands so far, it's been 100%. These are real results. I'm not making this up. You know, I almost feel bad about it. Like if I had 99%, people would believe me, but because I have 100%, nobody wants to believe this is true. So you can believe what you want. But I can look a mother in the eye and tell her, yeah, I'm going to do this operation. And the likelihood of success is almost 100%. And your kid is going to have a healed leg. They can run, jump, play. They can do any sports they want. I do use a brace for outside the house. And I do have, it's a articulated AFO. So it's below the knee, articulated AFO. Once they're about 6 or 7, I just use something that looks like a soccer, you guys refer to as football, shin splint, you know, just like that shin guard. And it just sandwiches the leg. And that's all I use. I even have one kid who does kickboxing. I didn't feel good about it, but I did give permission and I signed the form. So I have a kid kicking with the CPT. And they don't break, okay? These kids are okay. They're never gonna break. Actually, their tibias are stronger than yours and mine because they're just solid bone with 2 rods in them. So they're never gonna break. So look, I'm gonna leave it to others to reproduce these results. I think that's happening. I mean, one of your doctors in India modified the technique and I think he got pretty good results, not 100%, but somewhere around 80-something%. That's pretty good. I'm getting those reports from all around the world. I think there's a tendency always to, I think one of my attendings once told me the definition of an orthopedic surgeon is someone who changes the technique the first time they do it. Look, I recommend you stick to this technique exactly how I described it. I don't think it matters if you use a fixator versus a plate. So if that's easier for you, that's fine. One advantage of the plate is that you put it on before the bone graft. So the ends can't pull apart. When you go to sew the leg up, you got the bone graft in there, everything wants to telescope apart. And now the bone ends get bone graft in between them. by the time you put your fixator back, squeezing it together, you know, it's not as nicely organized. So if you are going to use a frame, have somebody holding the leg, accordioning it shut at all times, even during the closure, so that it can't separate out. But I had perfect success with the external fixator too. So I don't think that's what matters. I'm going to end by just showing you a couple of variations. Do I still have a few more minutes?
Yes. Yeah, we are overshooting, but yes, definitely you can continue. Definitely.
Okay. So we only I showed you type 4A, but what happens if you have migration of the fibula? What do you do there? And so in that case, you can see that the physis is above the level of the joint. So in that case, same operation, take down the hamartoma, but then you go more distal, you find your peroneal artery, you know, it goes through from the back to the front. If you've managed to save it, fine. If you didn't, fine. Move it out of the way. I usually pull it medially. And then you see the ligament, the syndesmotic ligaments here, and you release them. The front one, the back one. And once you've released the syndesmotic ligament, then you go ahead and do the operation on the tibia as we did before. You cut the bone ends, you put in the Fassier-Duval nail, you add the plate. So you do all that part. Why? You need a stable tibia if you're going to push the fibula down. You need a stable tibia. So once you've done that, you now grab the fibula and push it distally. And you've already put a wire inside, so it's ready. And then once you get it down to station, and it moves very easily because you release the ligaments, you pin it with a wire and you just bend that wire and leave it in place. And then you cut only then do you cut the fibula, because now you know how much overlap, and then you advance the rod in the fibula the rest of the way and bury the wire in the fibula. So that's the variation you do. And of course you put in your bone graft and make sure it goes way, way down, and you cover it with the muscle and you're finished. And, you know, so you can see here's a fibular wire here. Okay. Now let's look at this girl. She's got type 4B. Look at her remnant of fibula here. And it's a very distal one. And this is when she's 6 months. Look at the size of this. Now look at 14 months. It disappeared. She has nothing. She has almost nothing. This is the shortest one I have. Okay. So can you treat that? And you know, this is where, again, I'm going to comment about putting the rod through the ankle. Can you treat that without putting a rod through the ankle? And the answer is yes. And if you're using an Alizarov, you're going to have to put the wires in the epiphysis. If you're using a plate, you have to put the screws in the epiphysis. And there it is, cross union. Means you got the T plate on in the epiphysis, holding this very well. You brought the fibula down, and then you see the fibula transfixed with the wire. Look at that bridge. Look at the fibula. It's at station. You see that? And our screws are in the epiphysis. So 3 months after surgery, I took that out. And look at this, the plate's moving. It's growing. So it's growing away from the plate, proving that, in fact, I didn't think this growth plate would survive, but it did. Really remarkable. Here's 16 months post-op. It's grown so much that I have recently, and I don't have the final x-rays, I recently changed the rod for a bigger one. But look at that. Look how far it grew away from that plate. Look at this cross union. And you saw how tiny this thing was. It was only a few millimeters. Okay. Another one, 12-month-old. Look at the ages, 12-month-old type 4B CPT with NF. Okay, look at this remnant of the fibula down here. It's nothing. And here, that's the fibular wire right there. And fibula was pinned in place. You see here the cancellous bone between the bones. And then cross union here, 3 months after surgery, everything's healed. CPT's healed, cross union's healed. It looks phenomenal. Look at this. And then 2 years post-op. Now she has a little procurvatum of the ankle, and if I lengthen her, which she needs some lengthening, I'll correct that. Now, type 1, when you have no break. So this is very controversial. I mean, should you break these? Everyone braces these. You don't want to leave your ankle in this position. You get secondary changes. They get a calcaneus deformity. They get weakness of the gastrocnemius. They get a cavus deformity of the foot. They eventually get valgus of the ankle. This is not a good position. And so if you can get the ones that have a CPT that are broken, healed, why can't you get one that's not broken, healed? Only difference is an osteotomy. So I remove the membrane and then I do an osteotomy. And I do an osteotomy. And then I overlap the bone ends. And now I'm going to need to do some shortening. And so this determines how much shortening I'm going to do to get 2 flat ends. I mean, nice wide ends. Okay. And then I rod it, plate it, and only then do I cut my fibula. Remember, the fibula cut is done later. And then you cut your fibula and you rod the fibula with the wire. And that's it. And then you bone graft it, of course, and they heal. So type 1 is not difficult. This is one of the first plate cases I ever did. And I wasn't even using the plate I use now, but you can see this is a type 1. The fibula and tibia are intact. And you can see I broke it. And there's a plate there, cross union. And I wasn't making such a wide cross union then. Now I make a much wider one, and or longer one, I mean. But you can see that you get rotation control, you get compression with the plate, and there's the patient. I exchanged the Fassier-Duval nail in this patient, and because the bone was deviating down here, I did not cross into the epiphysis. I put in fact, this nail sunk inside. So now it's permanently inside the tibia, protecting this area. It'll never move away. And, you know, that's the final result, 3.5 years post-op. It's a boy from Sweden. He's got this CPT, NF. He's a type 2 because he's got a broken fibula. Okay. But the tibia is intact. So I break the tibia. And everybody's like, oh, you're going to break the tibia. That's terrible. Why is it terrible? The deformed tibia, his ankle's getting into trouble. Now he's got a cross union and it heals beautifully. His leg is perfectly straight. And I think I even corrected his fibula. You can see syndesmotic washer here for the fibula. And he's got a beautiful, you know, cross union there. He's never going to have a problem. And I've changed his rod out since then. There's the new rod. And when I change the rod out, I take the plate out. So that's when I remove the plate, when I change the rod out. And an older girl, she's 6, you know, again, she got pain, but no fracture. So, but you can't do this without cutting the bone. So sometimes you need to do a hemicorticotomy. So I did a hemicorticotomy. You got to make sure you don't strip your periosteum over the whole thing. You got to stop here so that you have living periosteum here. Otherwise, this bone will die. And then you can see, got a cross union there. The osteotomy healed, no problem. And that's it. Okay, so that's just to give you a good cross section of cases. And I will now unshare my screen and open it for questions.
Yeah, excellent. Very difficult cases and very good result. I am sure that our panelists as well as audience are going to have a lot of questions. One thing I would like to start with, how do you manage the shortening?
You mean how much shortening, or what's the effect of it, or you mean you're talking about the leg length difference?
Yeah, leg length discrepancy.
Right. So I separate the treatment of the CPT from the lengthening. And but I'm treating very young children. When I was using the X-Fix, I was, for older children, big ones, I was doing them at the same time, doing a proximal osteotomy and lengthening. Now I'm not doing that. For the older children, now I put an implantable nail in. And I just use a short one because they have very narrow tibias. So I use a short one in the upper tibia. I basically always now do the lengthening as a separate treatment. But I won't do it for 2 to 3 years. Why? So a very interesting phenomenon happens with the cross union. Soon as you do the cross union, the kids start weight bearing fully, running, jumping, doing everything. They become incredibly active and they stimulate growth. And we've seen incredible growth stimulation. So much so that I have 2 or 3 children that the CPT leg is now the long leg. It started off 1 centimeter short and ended up 1 centimeter long. Okay, just from growth stimulation. So it showed me that they have the potential to grow up to sometimes 2 centimeters on their own to make up. So I leave them alone and I follow them. And I think if their distal growth plate is competent, they get this growth stimulation and they may gain 1 or 2 centimeters on their own. If they don't, or if they've got a very large discrepancy, then I will use either an external fixator or at a later age, a nail, and lengthen them. Very important, the level of the osteotomy. So because this is still, NF or CPT or whatever type bone, they have the potential to create a new pseudoarthrosis. So before I do any bony work, I don't mean rod change. Rod change is not bony work. That's hardware work. Bony work means you're cutting bone, you're repairing a CPT, anything like that. So if I'm cutting bone, I will give them zoledronic acid around the time of surgery. Now, because if for pure lengthening, I'm not taking a bone graft, it doesn't have to be before the surgery. It can be after. So they get zoledronic acid either just before or just after the surgery, even for a lengthening. And I keep my osteotomy very metaphyseal.
Okay, thank you.
Have any problems with the osteogenesis, bone formation at the corticotomy site?
So I've not had much problem, but I don't do diaphyseal lengthenings in these kids. I'm doing very high lengthenings, and I think that may account for why I don't seem to have a problem.
Yes, Manish.
Professor Dror, what is the dose of zoledronic acid infusion?
I don't have it in front of me. I think it's either 0.2 or 0.02. It's in my article. You have to look it up.
And Professor Dror, would it be more appropriate to give a S-shaped incision than a longitudinal incision because you are doing shortening? So longitudinal incision, sometimes they open up and you shorten it.
Yeah, you're not doing that with these procedures. You're not doing that much shortening. So you don't have problems with these closing these incisions. I mean, your point's well taken. If you do a lot of shortening of transverse incision, it's better. But remember, you need a lot of exposure. You're never going to get that with a transverse incision. So you need a longitudinal incision to resect the hamartoma and all this other stuff you're doing. But the skin is not usually a problem, even with very bad ones.
Professor Draw, there are a couple of questions from the audience. How early would you operate a fresh case of CPT?
So I start around 12 months of age, even if they have it earlier. And the reason is, first of all, our hematologist won't give the zoledronic acid prior to that age. So they don't like to give that drug before 12 months. The youngest I think I've done is 11 months. The second thing is the implants themselves that we have are limiting in that below that, you're not able to accommodate a 3.2 millimeter Fassier-Duval. You're not able to accommodate these plates. Even some of the plates are 1.5 millimeter screws, but you really, by 1 year of age, it's much easier. Even by 18 months, it's a lot easier. You don't want to go too late because you get secondary changes. So you're trying to avoid all these secondary changes, which include leg length difference, valgus foot deformity, cavus foot deformity, calcaneus ankle deformity, and so on.
And as Professor Draw, how long will you use the brace? Till skeletal maturity, or you were told about 6 years?
This it's a great question. The bone is so strong. I don't know if they need a brace. I shouldn't say that, right?
Okay.
It's so strong. I'm getting close to the end of my career, and I really like that number, 100% union, no refractures. I plan to keep that till I retire. So I don't want to change anything that I've been doing. I have some patients who, without my permission, discontinued the use of the brace. They're not breaking, okay? So I suspect the brace is probably excessive, like belt and suspenders together. You don't need both. And, I think as long as you change the rod frequently, you're probably okay. But now what I do is I let them in the house walk around without a brace, and out of the house when they're doing sports and activities and bicycling and running, jumping, all that, wear the brace. But it is an articulated AFO, so they have free ankle motion, not the type that doesn't permit down motion. So they have free up and down motion. And then at about 6 years of age, I change it to the soccer shin pad, which has no fixation on the foot at all.
Dr. Milind has a question for you. How much BMP and periosteum contribute to union?
I think, look, I haven't done a huge number of cases without BMP, but I have done a handful, 5 or 6 cases, and they all united. I have several colleagues who've done this without BMP. They've all united. I think the key is the bone graft. I would make up for the lack of BMP by making sure you do the bone graft exactly the way I do it. Okay, don't reinvent the wheel on this one. Okay, so the one article is published in the Indian Journal with modified technique of mine, doesn't have 100% results. Okay, I'm certain that that's true, and the cross unions are really small. And what does that doctor do? They harvest cortical bone from the other tibia, from the iliac crest, and so on. It's not what I described. You want to reinvent a new technique, that's fine. But right now we've set the standard. You can't get better than what we have. So you need to try and match it. And once you've matched it, if then you want to start playing around and changing things, that's fine. But you need to get to my level first, and then start changing things. And I'm not talking about me personal level, but if you know, the level that we set the bar very high. 100 and 0 is very high. So that's what you need. If you can achieve that, okay, then you can start saying, okay, I'm not going to put the periosteal graft. Maybe it's not needed. Probably true, by the way. I'm not going to do this, and I'm not going to do this. And then if you start seeing that you're getting worse results, you know, because I don't know if every little step is needed, but it's kind of like Coca-Cola. You know, they have this secret recipe, and it's been like that for 90 years. And if you change any one thing, maybe it's not Coke Classic anymore. So this works. And I don't know if you change something, if it'll still work as well.
Yes, Hitesh.
I have one question. What would you do for a type 2A and 2B? You mentioned about 1, 3, and 4.
I showed one. I showed a 2A. It's the same. You know, so this is I'll tell you a little story. I remember when I was a young resident in 1981, I had the privilege, or 1980, I had the privilege of seeing Sir John Charnley. He came to Toronto where I was a resident, and they showed him one. Said total joint replacement, total joint replacement, total joint replacement. So you can go through type 1, cross union, type 2A, cross union, type 2B, cross union, type 3, cross union, type 4, cross union. The only case where I might not do it is if I have a huge bone defect, which is the 4C. And there, if it's not too big and I can bring the ends together, I'll do a cross union. Okay. But if it's too big, then I think then you have to consider vascularized fibula or bone transport. Those are your two big, or musculae. So people ask me, what's the role for musculae, vascularized fibula, and bone transport? 4C, only 4C. And so there you start. Look, in my 33 years in practice, did have, I don't do the vascular fibula technique, did have a microvascular guy do a fibula for me on a patient who someone had resected everything, and they had a 20-centimeter defect. Okay. So we took the fibula from the other side for 20 centimeters. It was a great technique, right? And you might even lengthen the leg first, get it out to length, you know, just the soft tissue, and take the biggest piece of fibula. Costs the same, you know? And so that's a great indication. I had one where someone resected everything and had an 8-centimeter defect. I did a bone transport, okay? I had one recently from Italy that had a 4-centimeter defect, and I was able to shorten it all at once, and I did a cross union. Okay. So that's why I say there's only the 4C, but 1 to 4B, all cross union. Very boring. The only variation, what you do with the fibula. And if you have to break it, if it's not broken, like the tibia in type 1 and 2, you have to break the tibia.
One more question. What are your tricks for the revision surgery for changing the rod?
Yeah, so changing the rod, you know, it's the Fassier-Duval system. It's pretty easy to take out the female end. The male end is a challenge. They do have, so they have a special extractor. It doesn't work very well. Very hard to get it out with that. There's now these drills that they're cannulated, and you can drill over top of your rod, your male rod. And sometimes that helps you get it out. But the easiest way to get it out is you go retrograde. You pass a wire through the calcaneus, through the talus, and you have to target your rod. So on AP and lateral view, you get your wire right up to the end of the rod. Then a 3.2 cannulated drill. That's the only time I make a hole in the ankle, okay? And then you tap that 3.2 drill bit and it pushes the male end out. That's the best trick.
Yes, Manish.
There is a question from Dr. Atul Bahadur. Professor Dror, your previous classification of mobile and stiff type, with or without bone defect, does stiff one do better than the other one?
No, because it makes no difference.
It makes.
So in other words, yeah, El Rasasi and I published a classification, based on a review of my cases in the 1990s, and it was atrophic bone ends, mobile, and atrophic bone ends with previous failed surgery, and then stiff bone ends and wide. And at the time, it changed how we were treating it. With the stiff ones, we were distracting or compressing. We weren't actually opening the pseudoarthrosis. The atrophic ones are the ones we opened, we bone grafted, and so on. And in fact, the way I came on the cross-union technique was treating the atrophic type. And I developed the bone graft harvest technique in 2002. And it gave me so much bone that sometimes when I would put the bone graft in there, it would create a cross union by accident. I was trying to wrap the bone graft around the bone. I published a paper on periosteal grafting, and that's where we started using the periosteum and this bone graft, even BMP. But we weren't trying to create a cross union. But it happened. And when I went back and reviewed some of these cases, even going back to 1999 in my series, I found cross unions. They never broke. That's when the light bulb went on. Okay. So ironically, I was creating cross unions since 1999, which ironically is when In-Ho Choi started doing this, but I wasn't doing it intentionally. And that's why I give them credit, because they intentionally were creating cross unions. I wasn't intentionally creating cross unions. There's even a paper from 1990 where Johnson's group were doing posterolateral bone graft like you would do for trauma. Well, when you do posterolateral bone graft, you get a cross union. And they had some success with that, but they never even talked about the concept of cross union. They weren't intentionally trying to create a cross union. But they were the first ever to mention that some of the cases had a cross union. The light bulb did not go on in their series from the year 2000 that this technique, they were doing it since 1973. Okay, they published in 2000 the review, and it was just a few of the authors were doing posterolateral bone graft, and some of them got cross unions. So it's been out there. It wasn't out as a protocol, it wasn't out as an approach, and it wasn't out as a technique. The only two papers, only two authors that really recognized the significance of the cross union was In-Ho Choi and his group and myself. And so, you can assign credit to whoever you want. I don't care. Our techniques are different. That's why I call mine cross union protocol. But the key is the cross union.
Yes, Manish.
Dr. Milind wants to thank you, but he says that he had asked a question about BMP and periosteum contribution to union. He wants to know what about the periosteum, how much it contributes.
Yeah, so I've done some without that. I think in retrospect, it's again a kitchen sink thing. I threw everything in there that I had, you know, everything in my kitchen I threw inside that leg, including the periosteum. You know, I published a paper 2008 in Core on periosteograft, so I had to use it. I think it's not important. I don't think you need it at all. You know, again, I keep doing it because I told you I don't want to change my formula. I think it's really unimportant, and a few times I didn't do it, and it makes no difference. So if I had to keep this down to the minimum that you need to do the rodding. Doesn't have to be telescopic, but you need to do the rodding and don't go through the ankle. One, you need to remove, and you got to rod both bones. Two, you need either the fixator or the plate, because you need to have rotational control and a little bit of compression, or prevent distraction. It's not so much important compression, but remember, this thing wants to pull apart because you shortened a little bit. You need to remove the hamartoma from both sides so that they have bare surfaces, okay? And you need to do it well past the fibular non-union. And lastly, you need to do the, you need to have a lot of autogenous cancellous bone. And I would add the zoledronic acid as essential as well. Preoperative treatment with zoledronic acid. Even if you don't do the postoperative, you need the preoperative. So those to me are the essential abbreviated version of this technique. So leave out the periosteum, leave out the BMP. What else did we leave out? Nothing. Those are the two elements that are not critical.
So last question, can I ask Dr. Dhiren?
Yeah, please, please.
One audience wants to know that you had already told that you remove plate when you change the telescoping rod, but they say that whether this plate will block the telescoping?
No, it doesn't block it, because I mean, I guess you have to be careful that the screws are not impinging on the plate. It doesn't block the telescoping. It can actually block, well, it blocks the sliding. So it could do that. And you've seen occasionally the rod pulls out from the top or it pulls up from the bottom. So I think you do have to be careful that the screws don't touch the rod.
Okay, now I think I request our secretary, Dr. Sandeep, to pass a vote of thanks.
Thank you, Dhiren bhai. So thank you, Dr. Professor Dror Paley. It's been really wonderful, and you can't really argue with success. And you have shown that once you have 100%, there is no room for experimentation, especially for people who will be trying this technique for the first time. And I think the greatest takeaway for me has been the cross-sectional amount of diameter of bone that you create, which resists the refracture rates. So it's not only achieving the fracture, but making sure that it doesn't break again. And that depends on the cross union. And the best way to achieve that 100% of the times is to follow everything that you have said. But as you said, you are in a position to experiment. And as you rightly put in the end, if you have to eliminate a few things which may be expensive, they would be BMP and periosteum, but all other steps need to be followed. So thank you very much from Pediatric Orthopaedic Society of India and Asami. And we look forward to hearing from you again in the future very, very soon. Thank you very much, Dr. Dror.
Thank you.
Thank you, Dr. Dror. Thank you.
Thank you.
Thank you
Yes.
all. My
Yeah,
pleasure.
thank you. Yeah.
Good night.
Take care. Have a good night.
Yeah.